Everyone could be here tonight to talk about bladder control issues. I'm Dr. Robert Bradford. I'm with Advanced Urology Institute in Tallahassee, Florida. And hopefully the information that we present tonight will help any of you with overactive bladder issues, incontinence issues, and we'll hopefully be able to give you some potential solutions and at least get you started along this pathway. So I'm Dr. Bradford. I'm a urologist. I've been in practice for, since 1996 here in Tallahassee, Florida. I went to Davidson College and then to medical school in Charleston, and then did my residency at the University of Florida in Gainesville. I've got an interest in female incontinence and oncology and pediatrics, but I find incontinence particularly satisfactory because so often you can really change someone's quality of life in a relatively quick period of time, and that's enormously rewarding. There are the urine, as you guys may know, is made up in the kidneys. The kidneys are up in your upper abdomen, and the urine traverses the ureters, the tubes between the kidneys and the bladder, to the bladder where the urine is stored. One of the issues with incontinence can have to do with the way that urine is stored, which is a complex process, which entails a coordination between the bladder muscle, the nerves that innervate the bladder, and the sphincter that lies below the bladder. The bladder muscle itself is what we call the detrusor muscle. When it contracts, urine is expelled from the bladder through the urethra, which is the tube leading out of the bladder to the outside world. All parts of the urinary tract have got to work in a coordinated fashion for urination to be appropriate. Overactive bladder is a very prevalent condition in the United States and throughout the world. We think in the U.S. alone, 50 million people are affected by overactive bladder. 25 to 33% of the people in the U.S. actually suffer from overactive bladder. The symptoms can vary from person to person. It can consist of frequency and urgency, urge-related leakage, where you get a sudden intense urge to go and leak, stress incontinence, which is leakage with coughing, sneezing, and laughing, and even overflow incontinence. The treatments vary depending on the type of incontinence that one has. So overactive bladder is just kind of a catch-all term that refers to a sudden uncontrolled need or urge to urinate, often associated with frequency of urination. It's not a disease, although some disease processes can cause this. Most of the time, this is what we call idiopathic. We don't have one clear explanation for it. Indications of overactive bladder would be trouble holding your urine, sudden strong urges to go to the bathroom. Many times you can't control these urges. Going to the bathroom 8 or more times in a day, accidental leakage before you can get to the restroom. Some people say they get out of their car, they take the keys out of their pocket to go open the front door, and they get an overwhelming urge to go and can't quite make it to the bathroom. Other people with running water might feel like they've got to go and suddenly have to urinate and may lose control. This can be disruptive to sleep. If you get up more than 2 times at night, that also can be a sign of overactive bladder. So incontinence takes different forms. They're what we call urge incontinence, stress incontinence, and overflow incontinence. Stress incontinence is when you leak with coughing, sneezing, laughing, exercise, stooping over, sometimes during sexual intercourse. This is obviously very annoying. Urge incontinence is a completely different category of leakage, and that's often associated with the overactive bladder with a sudden strong urge to urinate. You might feel a spasm in your bladder area, and you just can't control it. It's just suddenly coming out. It's more common in women. Overflow incontinence is probably more common in men, but it's associated with an overfull bladder and a sudden uncontrolled ability to control the urine. We can see this in men that are in urinary retention, or even women that are in urinary retention, where the bladder just at some point gets so full it automatically empties itself. So what causes bladder control problems? Bladder control problems can, as I said earlier, be idiopathic with no clear explanation. We can also see bladder control problems with more serious conditions like bladder cancer, inflammation, stones in the bladder, stones in the urine tubes. We can see it with diabetes. We can see it with an enlarged prostate gland in men. We can see it in estrogen deficiency in women after menopause. And sometimes we can see it with spinal cord conditions like herniated discs, multiple sclerosis, Parkinson's disease, and other neurologic conditions. Your urologist will closely scrutinize you to understand if some of these issues could be present, and if so, if further workup is indicated. Some of the things that cause urgency and frequency also might be foods that we consume. Caffeine can aggravate your bladder and make you feel the need to urinate, not only because it stimulates the soft muscle of the bladder, the smooth muscle of the bladder, but also because it makes you generate more urine. Obesity sometimes can worsen stress incontinence. As I said earlier, Parkinson's disease, multiple sclerosis can affect the upper motor neuron system and can lead to spasticity of the bladder. There are upper motor nerve pathways that descend from the brain down the spinal cord, and with nerves exiting to the bladder that exercise a controlling influence on the bladder, a calming influence on the bladder. Some of these neurologic conditions can result in the disruption of these pathways and spasticity of the bladder, often associated with urge-related leakage. Pregnancy can cause permanent damage to the muscles that support the bladder and cause the bladder to descend vertically, and that can lead to stress incontinence. Radiation can cause bladder spasticity and make your bladder a less compliant, stretchy reservoir that's able to store urine at low pressure, so that can lead to leakage. Pelvic surgery can cause issues not only with urinary retention, but spasticity. Urinary tract infections can cause an acute issue with the urinary control. And pelvic prolapse, that means tissues that bulge from the vagina, either from the back of the vagina, the roof of the vagina, or the floor of the vagina. Again, when you see a urologist, all these things are considered and are evaluated for during the physical exam, not only the physical examination of your body, but in the questioning around the time of your encounter. So bladder control issues are diagnosed in a number of ways. First of all, they can just be diagnosed in part by the history that you give the physician. The physician urologist is trained to ask very specific questions to help delineate what the source of your leakage might be. We can also perform stress tests where we actually get you to have you come in with a full bladder and ask you to cough or sneeze and look for leakage. Usually that's during a pelvic exam. There is a special test called urodynamics, which can help us determine, sometimes in more complex situations, the exact reason why a patient might leak. This is a test where a small catheter is placed into the bladder, water is instilled, the patient is asked to report when they first feel the urine, feel a full bladder, or have first sensation of filling. When they feel full, we can look for uninhibited contractions of the bladder during the filling process and various other things. And this can be very helpful in some complex situations. We also sometimes perform a cystoscopy. That means looking into the bladder with a little lighted telescope. And that can show us if there's any abnormalities of the lining of the bladder, if there are stones, tumors, strictures of the water channel, scarring of the water channel. urethra, or any other situations that might lead to leakage. We check the urine, and we can also check to see how well the bladder empties by doing little ultrasounds of the bladder. That's called a post-void residual check. We also can do voiding diaries. These can be very helpful in ascertaining not only how frequent someone goes, but the actual volume. And sometimes we find that this is a more accurate measure of people's true frequency of urination, urine output during the day and at night, and the actual volumes that they void, and what fluids they put in their mouth around the time of voids. That can be very useful. So the least costly things and the simplest things that may make an impact on overactive bladder and incontinence could be just lifestyle changes, like being mindful of the foods that you put in your body, how much caffeine you drink, how much fluid you drink, trying to go urinate prior to exercise or heavy lifting. And sometimes things like Kegel maneuvers, which are exercises where you contract and squeeze the muscles in your pelvic floor and the P channel, the urethra. But if those really conservative measures don't work, oftentimes we will add medications. Medications are best for patients who have what we call urge incontinence. That's that sudden urge to go, severe frequency of urination, sometimes getting up multiple times at night. And these medications act to calm the bladder muscle, to allow your bladder to store more urine before you perceive the need to urinate, and give you a bigger window of time when you feel the need to urinate to actually make it to the bathroom before leaking on yourself. Sometimes further tests like cystoscopies, as I discussed earlier, looking into the bladder, or the urodynamic, the bladder pressure test, can be useful. And if medications fail, and sometimes we use individual meds or combination meds, if those fails, we generally move on to what we call third line therapies. And third line therapies, or more advanced therapies for bladder control. Those might include, for overactive bladder and urge incontinence, sacral nerve root modulation. This is a way of actually upregulating the calming messages to the bladder through the bladder nerve roots. There's also what's called posterior tibial nerve root stimulation, where a small nerve behind the medial bump on your ankle, there's a nerve there that we can actually put a tiny little acupuncture needle into and stimulate with an electric current, and that can help some individuals with overactive bladder. And then there are also Botox injections into the bladder, which are done about every 6 months and will cause some partial paralysis of the bladder without generally causing trouble emptying the bladder, but will calm it down. So those are primarily for overactive bladder, urge-related incontinence. So again, conservative treatments, diet, timing of voiding, oral medications are kind of the first lines of treatment. And then if medications at 1 month haven't helped, we can try a second medication or add a second medication. Again, we may consider looking in the bladder during urodynamics, and then on to third line therapies for overactive bladder. We pretty much reviewed this. Weight loss, caffeine, diet, foods that are high in acid like berries, citrus, tomatoes may be irritating to some people and cause them to go to the bathroom more often. There are different types of medicines that we use for overactive bladder. There's two main classes. One is called an anticholinergic, and the other one is called a beta agonist. But these, what all you need to really understand is that these medications have different side effect profiles. The anticholinergic medications calm the bladder down, but can cause dry mouth, dry eyes, sometimes dizziness, sometimes some blurred vision. Those are less well tolerated than the newer class of medications called beta agonists, which don't cause dry mouth, but on occasion can cause elevated blood pressure. Your physician will work with you to figure out which of these medications your insurer will cover and which ones would be best in your particular situation. I'm going to skip this. Botox injections are actually injected into the bladder, and we inject usually somewhere between 100 and 200 units of Botox, and the results are generally felt within the first 3 to 5 days, and it can be very markedly better than before. We typically do this on patients who either can't tolerate medications or who are just failed medications. So let's move on to stress incontinence. This is leakage with coughing, sneezing, laughing, with exercise, aerobic classes. Typically, in the past, this was managed with Kegel exercises or less invasive treatment options like pelvic floor physical therapy. With Kegels, you just tighten and hold the external sphincter muscle. I tell people, pretend like someone's putting a $100 bill between your butt cheeks and you're holding on with all your might. So it's that kind of a motion to squeeze and hold. And usually I tell people to do that for about 15 seconds and do that multiple times in an hour and just throughout the day. And that can really sometimes help strengthen that external sphincter muscle. Pelvic floor physical therapy is kind of Kegels on steroids. You actually work with a pelvic floor physical therapist to recognize and recruit and strengthen the pelvic floor muscles above and beyond the external sphincter muscle. And probably what happens is that strengthening of the pelvic floor lifts the bladder back into its more normal anatomic position as the bladder is suspended by a hammock of musculature in the pelvic floor. And as you tighten that musculature, it pushes the bladder back into a more normal position. This is probably why it helps with milder forms of stress incontinence. There are also urethral bulking agents. They're actually agents that we can inject through a fine needle underneath the lining of the P channel of the urethra beyond the sphincter. And this actually causes some coaptation of the urethra, and it increases the resistance to the outflow of urine. Coaptite and Bulkamid and Durasphere are some of the agents that have been used. Bulkamid is one of the newer agents, and I've had a lot of success with it in recent months. And finally, for those patients with a really severe incontinence that is not responsive to less invasive procedures, there are more involved surgical procedures like slings. Slings involve putting either a piece of mesh or a biologic material underneath the bladder neck to elevate and pull the bladder back into a more normal position. Those are still relatively minor procedures done in minimally invasive ways, typically with small incisions in the vagina and small puncture incisions, either to the left of the labia or in the lower tummy. And those procedures typically are done outpatient, and people recover pretty quickly, usually within 2 to 4 weeks after those surgeries. So that's kind of a summary of overactive bladder. It's a quick overview. I would be happy to take any questions anyone has that I could maybe clarify some of these areas or answer any specific questions. Any questions? And if there are no questions, I'll give it just another minute or two. We'll send you a link if you have questions that come up after the meeting. We'll be happy to reach back out to you. And I appreciate everyone's time tonight. I've got one question here. They're asking, what does the Bulkamid procedure entail? So the Bulkamid procedure is a procedure that's used to treat stress incontinence. That's leakage with coughing, sneezing, laughing, and activities. What I love about this procedure is it's minimally invasive. It can be done with some sedation in the office. It's an outpatient procedure. There's virtually no recovery or time after this procedure. You could go back to your normal daily activities the following day. There's minimal, if any, pain associated with this. And what it involves is putting you under some sedation, looking into the urethra, the tube between your bladder and the outside world. And we actually take a fine needle and inject a bulking agent, which is a soft gel-like material underneath the lining of the P channel. And as we inject it, we eject it at the 10 o'clock position, the 5 o'clock position, the 7 o'clock position, and the 1 o'clock position. It begins to push the lining of the water channel in closer so that it begins to pinch off the water channel. Not so tight that it puts you into retention of urine, although that's a rare consequence, but just enough to increase the resistance to the outflow of urine. Most women notice that they pee really strong. They just don't leak at all. And the results are immediate, and I've had very excellent results with that. One patient asks if Kegel balls assist with strengthening the pelvic floor. I think they do. What I found is that Kegels and Kegel-related exercises can help with milder forms of incontinence. One of the disadvantages is that you will have to continue to do these exercises at regular intervals. If a lot of ladies will notice improvement and then they'll stop doing the exercises and their symptoms return. So that's one of the annoyances with these exercises. But if you don't mind doing them and you've got mild incontinence, a lot of times these can be very helpful ways to control your leakage. Another question is, what is the relationship between overactive bladder and an enlarged prostate? Interestingly, about 70% of men that have an enlarged prostate will also have overactive bladder. In other words, they'll have symptoms of urgency, frequency, and occasionally urge-related leakage. And so it's common in men. Sometimes not only do we give them medicines to help empty their bladder, but we'll also give them medicines to help calm their bladder down. And we can give these two medicines in concert, and they often work well. So one of the questions is, can you address the stimulator? There's something called an axonics or a Medtronic neuromodulator. And this is a device that we use to stimulate the nerves going to the bladder, and in some complex mechanism that we don't fully comprehend, increase the calming messages to the bladder. And the way that this is done is initially we do what's called a test lead placement, where we put a very fine lead wire through a hollow needle in close proximity to the nerve going to the bladder. Now, this is introduced in a location that's nowhere near the spinal cord. It's extremely safe with exceedingly rare complications. This wire is about as fine as the finest little lady's necklace you've ever seen. It goes through the skin up against the nerve root of the bladder. This wire is then taped to your lower back, and there's a little external pacing device that sends a very small current through the wire to the nerve. And you will wear that for 4 or 5 days. And it's like taking a test drive with the technology. And you will find out if that technology helps you with frequency, urgency, and urge-related leakage. and nocturia, getting up at night. If there's a significant greater than 50% improvement, then we typically will go on and implant a formal wire lead that goes underneath the skin and tunnels to a pocket where we attach the lead to a pacemaker. The pacemaker is a very tiny device that just goes underneath the skin, and it sends a small electric current through the lead to the nerve to calm it down. Very much like a heart pacemaker affects the heart. Here's a question about the artificial urinary sphincter procedure for men. So that's not something that I covered in this talk, but some men, and particularly men that have had a radical prostatectomy, complete removal of their prostate, can have an issue with urinary incontinence. And one of the ways that we have been able to solve that problem is to place an implant called an artificial urinary sphincter. And that sphincter is implanted by making an incision below the scrotum, dissecting down to the urethra, which is the tube that leads from the bladder out through the middle of the penis in a male. And we actually put a little inflatable cuff around the urethra. There's a small pump that is attached to that cuff that is implanted into the scrotum. And there is another tubing that goes to a reservoir that holds fluid that runs a hydraulic system. And that's implanted in the lower abdomen. And when this pump is pushed, the cuff deflates, water is taken out of the cuff, a man can urinate, and then about 1 or 2 minutes later, that cuff automatically refills and it enables a man to be continent of urine. So that is one mechanism of treating severe incontinence in a male, particularly in a post-prostatectomy male patient. Here's a question about a hysterectomy. Can it lead to incontinence? And actually, a hysterectomy is many times associated with urinary incontinence. The uterus itself can act as a support structure for the bladder, and I think in ways hold it up into place. And sometimes after a hysterectomy, the bladder will drop, and one might see stress incontinence, leakage with coughing, sneezing, and laughing. So they sometimes can occur. Not always, but on occasion we'll see that. So there's a question about Kegel exercises. And exactly how does one do a Kegel exercise? So a Kegel, probably the best way to do a Kegel is the next time you go to the bathroom, try to shut your stream off while you're urinating briefly. That squeezing action where you try to shut the sphincter off is actually closing the external urinary sphincter. It's not the bladder detrusor muscle. That's not the bladder that pushes the urine out of your bladder. It's the sphincter that actually can hold the urine in. That sphincter is supposed to relax normally while you're urinating. But in some individuals, that sphincter tone can get weak. And by doing those exercises, those Kegel exercises, you can strengthen that muscle. You can make it bigger. And I think that in part helps to increase the resistance to the outflow of urine. But to do the Kegel exercise best, it's not just a quick contraction. It's more of a hold for 15 seconds. Look at the second hand on your watch and hold it for 15 seconds and then let go. And then hold it for 15 seconds and let go. 15 seconds. So that can help with Kegels. That can help with incontinence. Here's another question. Can the bladder be controlled with medication in a situation where you have frequent urination? Absolutely. If you have severe urgency and frequency of urination, medications can absolutely help you. They don't always work, but they will work many, many times. Again, it depends on the mechanism. We will look for things like diabetes, for instance, that can cause frequent urination. With diabetes, you'll often have high levels of sugar in your bladder, which can make you go very frequently to the bathroom. But if you don't have diabetes and you have frequency, many times medicines can help you. If not a single med, sometimes dual meds can help you. There's a question about what can cause you to take longer to empty your bladder. One of the things that can cause you to take longer to empty your bladder is an enlarged prostate. Of course, this is primarily for men. As the prostate enlarges, it begins to create resistance to the outflow of urine from the bladder. Because the urine leaves the bladder, goes through the middle of the prostate gland, and then out through the urethra, through the penis. As the prostate enlarges, the resistance, or say the resistance that must be overcome is greater, and that can slow the exit of urine from the bladder. In women, one of the things that can make you take longer to empty your bladder would be constipation. I see ladies that are constipated. Actually, fecal impaction and constipation are one of the most common things that cause women to have trouble emptying their bladder. So paying attention to your bowel movements, how often you move your bowels, and the regularity of your bowel movements, taking stool softeners can sometimes help people with slow emptying bladders, particularly in women. There are some neurologic conditions that can cause the bladder to not empty properly. We can see this in diabetic neuropathy, people that have damage to their nerves from diabetes. That can also cause the bladder to not contract properly, or for people to lose the ability to feel their bladder when it's full, and that can result in a slow emptying of the bladder. I've got one last question that I'm going to answer here, and it is, can I speak to what causes night leakage? And night leakage can occur in many different scenarios. We can often see night leakage in children. We actually call that enuresis. It's very common in young children. About 10% of children 5 and younger will wet the bed at night. We see 10% of 5-year-olds, 5% of 10-year-olds, and 1% of 15-year-olds leak at night. And that's something that is almost always outgrown. We can also see that in overactive bladder and people with smaller capacity bladders, and that can definitely get better with medications. Occasionally, we'll see that with overflow incontinence with people that have just really difficulty emptying their bladder. They might leak at night because they have a decreased sense of consciousness, and may get their bladders really full, and they just have overflow incontinence. And occasionally we see it in ladies with stress incontinence that have very low bladder outlet resistance. And when they get just overfull at night, the urine may just actually come out. So anyway, so that I think summarizes things for the most part. Primarily, urologists manage incontinence. However, your primary care doctor may try to manage simpler forms of leakage with medications, and I think that's absolutely fine. But if you have a situation that's more complicated, your primary care is not able to address, you should definitely see a urologist in your local area, and they are experts in managing this problem. It's been a pleasure talking with you guys tonight. I hope this helped. I hope you're better informed, and good luck. Take care.